Design thinking, what a patient wants. Design thinking is a relatively new concept in many countries, including India. It is, however, already some decades old now, and having been practicing it for a few years now, Shrutin Shetty often gets asked what it is about, and for examples of its applications. For starters, he states that design thinking is a mindset, one that uses empathy and a set of tools to innovate and pursue complex opportunities or solve complex problems. It aims at better understanding the needs of the end user or identifying the root cause of a problem before beginning to innovate, and that always requires empathy, without which we often settle for one of the first few logical-seeming solutions that come to mind. Like many management and quality initiatives of yesteryears, design thinking too is currently receiving its share of a superficial hype. With time, however, Shrutin believes the hype will pass, leaving people with a better understanding and more sincere appreciation for the power of design thinking. Ordinarily, in a traditional problem-solving process, more constraints would almost lead to a dead end or teams giving up. Such complex projects are where design thinking works best. Charles Eames said, "Recognizing the need is the primary condition for design." Some years ago, Shrutin had undertaken a design thinking exercise for the pediatric oncology department of one of Asia's leading cancer hospitals. Sharing an overview of the same here, in case some of you are wondering what design thinking is all about. For him, design thinking is simply a humble approach to achieve a goal. Client: Pediatric Oncology Ward of one of Asia's leading cancer hospitals. Objective: improving the overall pediatric patient experience. Introduction: Shrutin was at the hospital with two of his associates to meet the expert medical oncologist regarding a project the associates and he were collaborating on. During interactions, the doctor expressed that patient feedback regarding the treatment has been positive. He and his colleagues, however, were always keen on knowing how they could further improve the patient experience. And given that the hospital offered free/heavily subsidized treatment to the poor, this was a humbling gesture. Shrutin offered to work on it. The task involved interacting with patient families, doctors, administrative and support staff. It was necessary to get a good understanding of each stakeholder group and interactions between groups in this bustling ecosystem. Fieldwork. Over the next 2 months, Shrutin spent several hours a day, or entire days, speaking with pediatric patient families. He broad-based the sample to include new admissions, patients currently undergoing treatment, and those there for checkups 1 to 3 years after successful treatments. The wonderful administrative staff helped identify patients in different segments, as well as introduce him to some of them, to make for a more comfortable interaction. Doctors had already provided considerable information from their perspective. He then spoke with administrative and support staff across the hospital, from admissions to inquiry and even third-party social service representatives. Initial observations and findings, based on information gleaned and using design thinking and other tools. Here were some findings. A. Patients/patient families. 90% of patients came from outside the city, 80% from outside the state. Nearly all patient families spoke 1 or more of 6 to 8 different languages. Wait times to meet a doctor were significant, between 2 to 6 hours or more. A slight delay in patient arrival could mean making another trip the following day. At least 2 family members accompanied each patient. It meant putting their normal lives on hold. It meant treatments that lasted between a few months to over a year or more. B. Staff was well-intentioned but mildly stressed and curt in responses to patient families. The staff dealt with hundreds of patients and family members on a regular basis. Some staff, on average, answered a request for direction to a particular building/room once every 2 to 4 minutes. Same was the case with some others about when their turn to meet a doctor would come, etc. Some staff members were aware of their curt disposition. However, they admitted that in the region a bulk of the patients came from, they were accustomed to speaking in a curt manner. Shrutin too realised the same based on his observations and interactions with some of them. It was an amusing dilemma, the innate intention to be more polite, but an audience that might complicate your work if you yielded. A solution he proposed aimed at solving that problem from the staff point of view. C. Hospital. The funding enabled treatment to be completely or partially subsidized for the poor. Doctors had requested that solutions be cost-effective if they were to be considered for implementing. Initial verdict from patients/patient families. The overall feedback regarding the existing patient experience at the hospital was stellar. This included quality of process, staff, doctors, etc. However, Shrutin soon realised that this view was biased by gratitude for a hospital that covers all or a large part of their medical expenses. Shrutin found himself back at the beginning. How do you improve patient experience when their treatment is paid for? Back to trying to identify the opportunity, he split the problem areas into 3. 1. Patient process, long wait times for paediatric patients to see a doctor. 2. Hospital process, duplicate room number problem, multiple inquiries to staff for directions to a room/ward, increased stress levels of staff. 3. Customer experience, how can an already good patient experience be made better without burdening the hospital resources? Again, using design thinking tools, Shrutin came up with initially unidentified problem areas. He also stumbled upon a promising solution for improving the patient experience. Cutting to the chase, my recommendations were as follows. 1. Patient process. Split patients into morning and afternoon batches to make for easier sequencing and much shorter waits. 2. Hospital process. Unique naming and numbering of rooms/wards, using words that cut across at least the 6 to 8 languages. Color coding of important rooms across buildings, with color-coded stripes on the wall to help patients follow the colored line, ideally with the color names being identifiable across languages. Color coding would significantly bring down the number of times staff got asked for directions. Patient families would be able to direct others. Color/line/name for room would help overcome language barriers. It would reduce staff stress levels and making them more productive and happy. And most importantly, 3. Customer experience. Propose tie-ups with companies nearby to start with for low to medium skill jobs that were individual independent, one that anyone could turn up to do it. That would ensure work continuity while not limiting patient treatment schedules. Thought behind it. What was clear was a free/almost free treatment and capable and polite doctors and staff. What design thinking helped him identify is how family members put their lives on hold as their child underwent treatment. Earning some money while they were in the city would help them buy small joys. It would help reduce the horrors of the disease and side effects of the treatment on their child. That's the only thing doctors and staff could not give. This would not burden hospital finances. Shrutin also proposed an alternate strategy option where patients would pay a very nominal fee for services from their salaries, stipends. This could bring newfound respect for the institution. The institution could also perhaps extend treatment to a few more patients with the same funds. Please note that coloured stripes and naming of rooms isn't part of design thinking. What is identifying underlying issues such as staff stress and its causative factors. So is identifying possible areas to delight a customer in an otherwise perfect-seeming environment. Hillman Curtis said, "The goal of a designer is to listen, observe, understand, sympathize, empathize, synthesize, and glean insights that enable him or her to make the invisible visible." Key learnings from this assignment. Customers might not always articulate what they want. Be aware of tendencies where the ecosystem might bias a customer's viewpoint, and, often, solving or even addressing one problem area could have benefits across multiple areas. Anyone can learn and practice design thinking. It needs a lot of empathy and involvement from you. It also requires an unwavering commitment towards customers, employees, and innovation. And it is especially for those who are comfortable grappling with lots of ambiguity and can stay true to the larger objective. According to MC Escher, only those who attempt the absurd will achieve the impossible.